Well, thank you very much, Ranjit. Good afternoon to all of you. I say good afternoon, but for me it's actually 10 past 9 in the evening. I'm speaking to you from Melbourne in Australia. I would just like to share my screen. Okay, share, and I just need to do this. Okay, are you able to see the full screen now?
Yes, absolutely, Albert. Please go ahead.
Okay, well, first of all, thank you very much, Ranjit, and my dear friend Dr. Chowdhury. I have very fond memories of the first time I visited you. It must be over 20 years ago now, when you were working together, and it strikes me that many of the issues which we are talking about this evening, we talked about in those first meetings. And thank you very much for your kind introduction, which is totally, in my opinion, undeserved. But anyway, look, I gave some thought to thinking, what could I say to add some value to this meeting, which perhaps it would not be said otherwise. And I want to share some personal reflections on issues which are affecting the field as I see it now. Some of these issues perhaps are not very directly impacting on your country, but I think that as time evolves, you will find that they will. And in fact, this evening we've already heard some of these issues mentioned, as I shall show. So I'm going to take each of the three main products. Of course, there are many more, but I'm going to take each of the three main products from plasma fractionation: albumin, immunoglobulin, and factor VIII, and discuss a specific issue related to each of them, which is actually applicable throughout the field. If I think about albumin, which is a product I've been involved in now for a large number of years, since I joined the PPTA. Before that, I wasn't really very interested in albumin. But since joining the PPTA, of course, I'm no longer in the PPTA now, I gained an interest in albumin. Albumin, as you know, was the very first real mass-produced plasma derivative. It was the result of the excellent work by Professor Cohn's group in Harvard University, and very quickly became the driver for procuring plasma globally, and stayed that way for a large number of years. Albumin initially was used to save lives of people who had suffered severe blood loss in battlefield injury, in burns, in trauma of various kinds. As the years have gone by and intensive care management has improved, the use of albumin in these circumstances has actually become less easy to justify, because with good modern technologies in relation to intensive care and emergency medicine, we can actually manage volume loss quite well in most patients, not all, with other solutions, including crystalloids, which are much less expensive. However, in the past 10 years or so, a number of so-called pharmacological benefits of albumin have been explored in relation to the albumin molecule's complex structure and its ability to exert various physiological actions in the body, including suppressing oxidant stress and things like that. And one of these indications has been very vigorously pursued in our countries, in the Western economies, and this is the use of albumin in severe sepsis. And what I'm showing you here is the basic summary of three very large randomized clinical trials. The SAFE study in Australia, which was carried out about 18 years ago, the EARS study, which was primarily driven by France, and the ALBIOS study with primary investigators based in Italy. And what you can see here is that when you compare survival between the groups who received albumin and the groups who did not receive albumin, always we get an improvement in survival with patients with sepsis in those who received albumin, but this is never reaching statistical significance in these large individual randomized clinical trials. And there is one study, the Albio study in Italy, which showed that in the subgroup of patients with septic shock, you got a certain statistical difference in survival, but not very large. However, if you look now at this most recently published meta-analysis, which takes those studies which I have just shown you together with other studies and combine them in a meta-analysis comparing benefits with albumin and benefits with crystalloid, you can see that effectively there is no statistically significant difference. And basically, patients with sepsis do equally well overall in randomized clinical trials combined in a meta-analysis when they are given crystalloid, which is something to think about in relation to sepsis. If we look at another indication, which is the use of albumin in long-term administration in patients with cirrhosis, this is the famous ANSWER study from Italy in Bologna, and you can see in this study that survival in patients, long-term survival in patients given albumin as well as standard medical treatment was significantly enhanced compared to those not given albumin. This study was published in The Lancet. It is a randomized clinical trial and it caused much interest some years ago. If, however, again, we look at a meta-analysis of patients from many studies in terms of them being given albumin in cirrhosis and ascites, you can see that again we have no difference in significant clinical benefit in terms of this other indication spurred on, fueled by the possibility of exploiting albumin's tertiary structure. And last of all, in terms of albumin, we go to the established indication. A lot of albumin is used in this context, especially in the United States in cardiac surgery. You can see, looking at this retrospective, I emphasize a retrospective cohort study in the United States, you can see a very significant benefit using albumin compared to crystalloid. But again, when we look at a randomized clinical trial as opposed to a retrospective cohort, this study from Finland, published a little earlier this year, shows no significant benefit. Why have I chosen albumin to make this point? The point I'm seeking to make is that plasma, as I think has already been mentioned by Thierry and others, is a very precious and very scarce resource. And we need to make sure that plasma is used to the best possible benefit for patients in terms of the products which are derived from it. And this means that we must always question indications, and we must also always practice evidence-based medicine. This is something I firmly believe in, and I have given you this example of albumin in the context of my first message to you, which is that clinically in transfusion we must continue to pursue the best practice evidence and continuously do clinical trials. I now go to the important issue which has been mentioned by Ranjit, which is the issue of self-sufficiency. In our economies in the West, the plasma supply, as everybody knows, has been driven for at least the last 15 years by the apparently never-ending increase in the demand of immunoglobulin. And much plasma is collected for immunoglobulin production, and at the moment, globally, in Europe, in the United States, everywhere where plasma is collected by the big industrial fractionators, we hear the slogan, we need more plasma for immunoglobulin. Let us look at this interesting example in terms of a small country in Europe. This is the Czech Republic. It is a relatively small country. It's a very nice country. I have visited it many times. The capital city, Prague, is one of the most lovely cities in Europe. It is a reasonably prosperous country. The GDP per capita is nearly $28,000 US. And believe it or not, my friends, this little country is the biggest producer per capita of plasma for fractionation in the world. On a per capita basis, the Czech Republic produces more plasma than anywhere else. The United States, other European countries such as Germany and Austria, they all lag behind the Czech Republic. Now, if you look at the Czech Republic's plasma collection, and this is data for 2021, which is the latest that we have, you will see that, as I said, there is this enormous volume of plasma which is collected compared to the population. 860,000 liters of plasma is collected. And if one had to take out of this plasma in the immunoglobulin using a yield of, I think Thierry would agree, of between 4 and 4.5 grams per liter, we can expect that the Czech Republic would have at its disposal 375 grams per thousand population of immunoglobulin, which, in terms of all that we know about the indications for immunoglobulin, is more than enough for the Czech Republic's patients who require this product. Much more than enough. Probably 2/3 to 1/2 more than enough will be generated. Is this happening? No, it is not. You will see from this slide that the very latest figures from the Czech Republic show us that rather than 375 grams per thousand of inhabitant, as we would expect from its plasma collection, the Czech Republic is consuming 70 grams per thousand. Now, I would say that 375 grams per thousand is too much, but 60 grams or 70 grams per thousand population is too little. The Czech patients are underserved. And the reason for this is very simple. There is no link in the Czech Republic and other countries which collect plasma, and I think that this is a very important point, between the actual collection of plasma, whether it is from the commercial paid donor sector or the voluntary recovered concurrent plasma sector. There is no link in the Czech Republic between this vast collection of plasma and the provision of product from this plasma to the Czech patients. The Czech plasma is all of it sold to the fractionators who use it to make product which they then offer on the open market to various countries, including the Czech Republic. And since there is no link and no public health infrastructure in the Czech Republic to ensure that the Czech plasma derives benefit for the Czech patients, like there is, for example, in Italy, this is not happening. And the reason why I put this point to you is to remember that self-sufficiency is not just a case of collecting more plasma. There has to be public health policy driven by the government to ensure that a community's plasma actually goes to benefit that community and not end up as a tradable, saleable commodity on the open market with all that entails for countries which do not necessarily have the funds to buy expensive immunoglobulin. I think that that is the second important point I wanted to illustrate with immunoglobulin. I now come to a point which has already been covered to some extent by both Dr. Chaudhry, both Thierry, and also mentioned by Ranjit. And this is the case of hemophilia. I'm going to talk about hemophilia A and what I call the tragedy, the continued tragedy of waste. This is the global prevalence of hemophilia A in terms of numbers of patients, estimated in the most recent publication from the clinician Alfonso Iorio, who is Italian, but who works in McMaster University in Canada, one of the most able minds in the field of hemophilia and evidence-based medicine in the world today. A close friend of mine, and I admire him greatly. And he has used sophisticated statistical methodology, which I personally don't understand, but I trust his estimates, to estimate that actually the global prevalence of hemophilia A is more than we previously thought, and it is over 1,125,000 patients are suffering in the world from hemophilia A. Now let me show you this slide, which shows you, and this is a slide from the Market Research Bureau, which we all depend on for data on the plasma industry, very reliable, very wide data, and generously put in the public domain. And this shows you the global collection of plasma for fractionation over the past 20 years. And you can see that it is continuously going up. You can see that there is a dip in the COVID years. It went down in 2020 and in 2021. My understanding is that this year, thanks mostly to the United States, because the vast majority of global plasma for fractionation in the world is collected in the United States, it is going up again. But the data we have here shows us this dip. But irrespective of that, you can see in this slide that there is a certain volume of plasma collected, about 70 million liters, and you can see that the vast majority of this plasma, increase in plasma collection in particular, is from the apheresis source plasma, most of it, not all, but more than 80% of it from the commercial sector, whereas the recovered concurrent plasma mentioned by Thierry earlier seems to be always stable and stagnant at that relatively low volume. Now, I have done a very simple set of calculations in relation to this plasma for fractionation which is being collected, and I estimate that if with proper management all this plasma, most of which is suitable for generating rich cryoprecipitate, is fractionated to factor 8, and again I look to Thierry for comment on my estimation of yield, but I think that 180 IUs of factor 8 per liter is a reasonable figure to aim for, and if this was extracted, we would have nearly 12,000 IUs for each patient in the world per year more than we have. And remember that many of those patients estimated by Alfonso Iorio are not actually diagnosed, so the amount of factor 8 able to be distributed from this hypothetical source of plasma cryoprecipitate is much, much more for the patients we know about. Is this happening? It is totally not happening. The vast majority of the cryoprecipitate generated from plasma for fractionation globally, unfortunately, is discarded because, thanks to the enormous, wonderful advances in biotechnology in the rich countries no longer use plasma-derived factor 8 for hemophilia A. And rather than some kind of mechanism, and we have much thinking to do about how to do this, and it is possible, I firmly believe, to channel this cryoprecipitate, but in the meantime, tens of millions, hundreds of millions of international units of factor 8 for patients with hemophilia A are being thrown away, and this is a global scandal. So I have reached the end of my thoughts, which I wanted to share with you. So I just want to summarize my basic ideas. I think that in transfusion medicine in general and in plasma product usage in particular, we need to use evidence-based medicine because plasma for fractionation is a scarce resource and we need to make sure that we are using it wisely. And one of the ways is to make sure that optimal use and indications which are recognized are what it is used for. I have shown you that it is not enough to proclaim, let's collect more plasma and let's get self-sufficiency, because unless there is a mechanism in the public health and within governments to ensure that there is a link between plasma collection and provision to patients, this plasma will simply flow towards the commercial sector and will find the best price irrespective of where it came from. And we have many examples for this. And finally, I have shown you one example, but I think there are several more whereby fractions which do not find a use in the developed world are being discarded to the great detriment of patients worldwide. And with that, Ranjit, I thank you very much again for your introduction, and I will stop here and look forward to the discussion later on. Thank you very much.